Thank you, everyone, for joining us. First, we want to ensure that everyone in the audience is ready and comfortable with the technical aspects of the webinar. As you'll see, closed captioning is enabled for today's webinar. We also have American Sign Language capabilities enabled in this meeting. You can activate it by clicking the interpretation icon on your Zoom navigation bar. If you need tech support during the webinar, please send a chat message to the host and we'll address it for you as quickly as we can. Lastly, if you have questions during the presentation, please enter them into the Q&A area. The questions will be sent directly to the presenters and moderators, and we'll have time at the end to address them. Next slide. I'd like to note that the views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect official policies of the U.S. Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide. I'm Jennifer Dolet-Shahi, and I'm going to be kicking us off today. I'm part of the Substance Abuse and Mental Health Services Administration's 988 CSR Crisis Systems Response, TTAC, which provides training and technical assistance, support to states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care. Along with our partners, W2 Consulting Corporation and Change Matrix, LLC, who have extensive experience with crisis services and technical assistance, the CSR-TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system. The goal, the goal of the CSR-TTAC is to support a crisis care system that is integrated, sustainable, and aligned with evidence-based and informed practices. In addition to support through formal structures like these workshops, the TTAC can also provide individualized technical assistance to crisis systems, organizations, and providers. My colleague is going to drop our email address in the chat in case you have questions or ongoing support needs, and you can reach out to our TA team. So here are a few of our TTAC workstream colleagues. In this workstream, we focus on advancing integration of substance use services into the crisis continuum. Bree Carr, Stephanie Lagallo, and Stephanie Liu all contributed to the presentation today. Next slide. And as I said, I'm Jennifer Dolet-Shahi, and along with my colleague, Megan McGregor, will be the face of this webinar today, but as with so many things, it takes a village. Next slide. Now I'm going to pass it over to Jill Mays, Division Director for Crisis System Transformation for the 988 and Behavioral Health Crisis Coordinating Office at SAMHSA.
Good afternoon, everyone, and welcome to today's webinar. It's really an honor for us to have each of you here with us today as we explore an issue that sits at the very heart of saving lives, and that's the powerful connection between crisis services and overdose prevention. As we begin thinking and gathering in this season of holidays and reflection, I'm reminded that while many people are celebrating, there are countless other people who are quietly struggling. The weight of loneliness, grief, financial strain, and the pressure to hold everything together often intensifies during this time of the year. And we know that these moments of vulnerability are precisely when crisis services, compassionate responders, and access to timely care can mean the difference between despair and hope, and sometimes even the difference between life and death. So I want to again thank every single one of you, the crisis counselors, peer specialists, mobile responders, clinicians, coordinators, data teams, program leaders, and all other partners across the crisis continuum who are represented here today. Your work is demanding, we know this, and it's often unseen, but always profoundly life-changing. You show up in the moments when others feel like they can't. You listen when someone's world is unraveling. You intervene when a life is hanging by a thread. And you remind people who are often at their lowest that they matter, and that recovery is still possible. So I'm reminded of a story shared recently by a crisis counselor. She answered a call from a young man who was on the verge of giving up after losing his housing, family connections, and almost all hope. He had overdosed twice earlier that month and said that this call was his last try. And over the next hour, that counselor stayed with him, steady, calm, and present. She connected him to a mobile crisis team who met him where he was. They brought not only Narcan and support, but they brought dignity, understanding, and a plan. And months later, that same young man sent a message saying, "Thank you for not hanging up on me. You helped me choose to live." So stories like this are not rare. They happen all the time because of you, because of your skill, your heart, and your willingness to stand in the gap when crisis and overdose risk intersect. So as we begin today's conversation in this webinar, let this be both a learning moment for us and a moment of affirmation. The work you do every day is shaping the trajectory of individuals, families, and entire communities. You're building a crisis system that sees people fully, beyond their pain, beyond their substance use, beyond their circumstances, and offers them a pathway towards safety, healing, and hope. So again, on behalf of the leadership here at SAMHSA, thank you for everything you do. Thank you for showing up during the holidays, on the hardest days, and even on the days that no one will even hear about the things that you do. Thank you for continuing to be a light in places where people need it most. So let's begin.
Thank you so much, Jill, for that welcome and centering us in this topic, and for all the support that you and your SAMHSA colleagues give in this incredibly important work. Next slide. I also want to briefly introduce our guest speaker, who we'll be hearing from shortly from another part of SAMHSA, the Center for Substance Abuse Prevention. She has a robust career as a behavioral health leader, and we're excited to get to learn from her as well today. Next slide. I'll briefly go over the learning objectives for today before passing it over to Sarah Potter to ground us in the current scope of the overdose crisis. I'll then discuss substance use and overdose in the context of crisis events and how to address overdose risk across the crisis continuum. My colleague Megan will then facilitate a Q&A period, during which we'll invite folks to raise their hands if they want to come off mute to ask any questions. Please also remember that you can submit questions throughout the webinar using the Q&A function or by entering it into the chat. It is easier for us to follow them in the Q&A tool than in the chat, but we will do our best, so apologies if anything is missed in the chat. We also have some questions that some of you submitted when you were registering for today's event, and we thank you for giving that some thought as you considered coming today. Megan will then lead us all in a mindfulness exercise and share some exciting upcoming events we have at the CSR-TTAC, as well as an upcoming learning collaborative. Finally, there'll be directions at the end of the webinar to receive a certificate of attendance for today's event. Next slide. So we've told you a little bit about our team, and Jill gave us some wonderful introduction and grounding to this work. And we'd really like to hear about all of you and how you come to this webinar. So we have two short polls, which my colleague will start now. First, on what pillar of the crisis system you work in, whether you're someone to contact, someone to respond, or a safe place for help. And then what best describes your role in your organization or in the crisis work that you do. So we'll leave that open for a little bit as folks start to respond. We're waiting for those poll responses. Remember that you can be thinking about your questions, and hopefully more will be solicited as we go through the content today. Okay, I will just give it another minute. And thank you all for sharing in the chat as well. It's great to see the engagement already. We appreciate it. Okay, with that, I think we will close the poll and show everyone the results. Wow, so really split between the different pillars. That's very exciting. We hope that this content lands for all of you as it's so important to be thinking about how substance use and substance use services need to show up in all three of the 988 crisis pillars. And then it sounds like we have a lot of folks who are really interacting with individuals, crisis workers, and case managers. Great. Next slide. Okay, so in this session, you'll learn how to define overdose prevention and response within the context of crisis care, the historical and system-wide factors contributing to the epidemic. We'll demonstrate how to apply overdose prevention strategies in crisis settings, identify some evidence-based approaches such as trauma-informed care, non-judgmental engagement, and linkage to treatment and recovery services. And finally, we'll talk about integrating SAMHSA's overdose prevention guidance into workflows and protocols for crisis response teams. With that, I'm going to pass it over to Sarah Potter, our colleague from SAMHSA's CSAP, to talk about the scope of the substance use and overdose crisis, as well as some of the risk factors for overdose.
Good afternoon, and thanks for joining. Special thank you to our friends at Alterum for all of the work that they continue to do with us and for the heavy lift on getting us ready for this session today, and all our friends at the 988 Center as well. Again, my name is Sarah Potter. I am from the Center for Substance Use Prevention at SAMHSA. And so we do a lot of work in preventing substance use and the initiation of substance use in the first place, but we also do a whole lot of work at the community level. Our folks on the ground are quite often sort of connectors between all of the folks that we saw in the audience today and members of the service system that are not represented on the call today too. So I like to think of our prevention system as connectors, and quite often we see areas to target sometimes that I want to talk about for us as we think about the systems and the complexities of the systems that we all work in. We don't need to go into all of the challenges, but I think we all know what some of those are. I want to give us some perspective, some food for thought on new areas. Hi, everybody. New areas that we might want to think about and new ways to approach some of the challenges in our communities and different ways to think about it from the prevention lens. Go ahead. Advance, please. So it wouldn't be a SAMHSA webinar if we did not start out with or it wouldn't be a SAMHSA commentary if we didn't start out with some data points. By way of kind of a snapshot, most of this data is from our National Survey on Drug Use and Health. You can find that online very easily. I pulled out just a couple of components that I wanted to talk about, although I do encourage you to look at that data and talk about what that means for your community. It is rich with resources and things that you can use to make the case and plan for targeted areas where you are really working on using the tools that you're going to learn about later today to strengthen your systems. So what we know is that overdose deaths remain significantly higher than they did even before 2020, where we saw tremendous spikes in overdose deaths. While we have seen some stabilization of use, so you hear good news about opioid use stabilizing, and we see some good indicator data about that. We should celebrate that, of course. We have learned a lot along the way, but there's still a lot of work to do. One of the things that I want to emphasize is that the initiation of substance use and the rates of substance use don't really fully reflect the prediction for overdose deaths. And so, what is clear actually in the data that we are looking at is that overdose outcomes have continued to worsen despite the sort of flat and promising rates in misuse that we are seeing. And so, what that tells us, does anybody have any guesses on why that would be if folks are not using as much, or we're seeing some stabilization in use rates? Why are we seeing worsening in overdose rates? Any guesses? Any guesses in the chat by my friends? You can get an imaginary $1 million prize. Yes. Increase in potency. Yep, here we go. Yep, drugs list, absolutely. So, drugs laced with fentanyl is a tremendous contributor. We've all been hearing about that for a really long time. And then comorbid use, so polysubstance use and things of that nature. Yet we all know there are a lot of people who need treatment who still don't have access to it. And I'm talking about substance use treatment here, but this really does play a big factor in what we are seeing when it comes to crisis care that is necessary, the prevalence and extreme nature of what our crisis teams and the overdose prevention kind of continuum is having to deal with and what we need to anticipate. So, as I said, use rates do not necessarily reflect to overdose rates. I wish it were that simple because we could just target where we're seeing use, put all our resources there, and it would fix the problem. But what we know is there are individual risk factors that come into play. There are community risk factors and lack of access in some areas more than others, thinking particularly about rural areas and some areas that are less resourced. Our systems and kind of the breakdowns and challenges in how our systems are able to work together. Like I said, we have made a lot of progress, but there's a lot of work to do there still. And then making sure that we are really focusing, and this is hard for us to do, I think, when we are in the midst of crisis care, but really to think about the prevention continuum, how to reduce risk, how to do the full response, and then how to link to various kinds of services. Jill mentioned all of the things that play into what folks need in these situations. And so linkages not only to treatment, but also to other kinds of care services. And that includes non-clinical care, that includes peer supports, all of our friends who are on the ground doing work to make sure that people have what they need to get well, stay well, and contribute to their communities. So the crisis rates are uneven. We know this. We still are seeing some regions, rural areas I just mentioned. We've heard a lot about American Indian populations lately, and then the challenges that we are focusing resources there. It's because there are disproportionately high overdose rates still in some of those areas. We see some areas of the country too that have been hit harder than others as well. So we can go in, use our NISTA data. You're going to hear about a lot of resources today to help you target and focus. Let's talk a little bit more about adverse childhood experiences and why you see this. I mentioned 3/4 of high school students have more than one adverse childhood experience. I want to take a minute to talk about this. Can you advance the slide, please? So, does anyone know what ACEs are? Do you know are you familiar with those? Yes, no, yeah, okay. Okay. So there are lots of ways to look at your community and think about where to target. Yes, thanks, guys. Appreciate you talking back to me. It's weird talking into a void. ACEs specifically are really tied very closely to the likelihood of opioid misuse, addiction, and fatal overdose rates. So this is why I wanted to bring this to the table for your consideration first. There's lots of data that is available in your community to target where gaps in resources are. But I want to talk about ACEs for just a moment. Because it really does help anchor why trauma-informed care is really essential and how we can think about where to focus resources and the impact of where people have been and where they come to us from when we see them in our systems. So what you see here is that 75%, and this is just high school students. So this is not adults, although when we're working with adults, their ACEs scores are also very relevant to us. But with high school students, right now, 75% have more than one ACE score. So if you look at the chart here, you'll see that's the lowest number. So if they have less than, or they have one ACE adverse childhood experience, you'll see they're more likely to be in a physical fight. That's the blue line. Now you see that jump up really, really high. So those higher levels on the right-hand side, so in a physical fight, 3.1 versus 1.3, that is the more ACEs you have, the more likely you are to have challenges in these areas and have a prevalence of these types of problems. So you can see prescription opioid misuse. If you have less than one or less, you have prevalence is 2.2, but you see that jump way, way, way up. And this is why I want to encourage you to think about what ACEs look like in your communities. Your community health workers do this kind of work. Your prevention folks do this kind of work as well. And quite often, these are reported through school settings and with our prevention providers and in our SUD systems. And you can really look at, okay, what are we looking at right now that we need to anticipate in our service systems going forward? And we need to plan for these things now so that we're able to respond. What we also know is that ACEs, especially for young people, very strongly contribute to long-term adult mortality rates. And for our young people, we gave the numbers of overdose deaths on the prior slide. For our young people, we can look at that and know that they are 10 times higher to have a mortality rate and that there are costs associated with that. And these things are not guesses. We can look at these things and figure out exactly where to place our services and anticipate to what extent we need to place our resources across the continuum of care, which you are going to hear much more about later. Please advance. Okay. So substance use, I talk a lot about substance use because I'm at the Center for Substance Use Prevention. We know it's chronic and progressive. We know that without services and supports, broad range of supports and low barrier services, the least we want no wrong doors, which is in many cases where our crisis teams and our systems sort of have an opportunity to bring people in and why this work is so important. 50% of folks have co-occurring mental illness. I mentioned this a moment ago that heavily increases the burden on our emergency rooms. Our 988 friends on the call with us can speak very directly to the increases in rates of call-ins and to what extent co-occurring mental illness and substance use really contribute to the folks who are calling in needing help and the complexity of how we need to be able to respond. Please advance. So doing this work is in some ways difficult, almost, of course, we always need more funding, more resources, more workforce. All of those things are perennial challenges and continue to be. I want to talk about some of the when you're on the ground, some of the difficult parts of making this stuff work. And hopefully you guys have not directly had the experience where you spend a very long time and get so many folks together, all well-intentioned, all fully on board and ready to commit to the broader service system, and then something changes and it all kind of falls apart. It could be a difference in leadership. It could be a grant from a key anchor partner now changes, and then there's a gap, and then things kind of fall apart across sector collaboration. And so I think in some ways, us thinking about how we're going to specifically target a particular area and make sure that we have continuous feedback loops and agreements to sustain changes in funding and staffing and people, and to really think about that as a system that you are fortifying, planning for, feeding, continuing to care for and develop. Just as much as we are thinking about the services, the types of services, and the levels of care, because it's often in the transitions that we lose people either literally lose people to overdose or lose them out of the system where in many cases their symptoms or challenges are progressing and becoming more complex, more expensive, more costly, and really more harmful to families and the people that we care about serving. So cross-sector collaboration is incredibly important. I want to, of course, a robust crisis care system and community support system is important, but when we think about our collaborations, it's really important to think about, we know we don't have all the resources we need. We know we don't have all the people we need. In some ways, it's thinking about what parts of the system in your community you might be able to use as a fulcrum, as a leverage point to gain some momentum, gain some attention, gain some traction on fortifying how the system works as a whole better. And again, this is part of why we're doing this session today. You're going to learn much more about the toolkit and the resources available. But I do want to at least acknowledge this and encourage you to think about this as a system as much as what services are needed across the continuum. Please go ahead and advance. So some of the fragmentation that we all know are between sometimes data systems simply just are not talking together. So on the behavioral health side, we are tracking certain things that emergency rooms are not. Hospitals are tracking different things than our crisis care teams are directly tracking. And in many cases, these are not the systems are not talking together and certainly not being used to plan for and anticipate areas where we need to fortify services and that care system that we were just talking about. So prevention and overdose response and crisis to care coverage is not distributed evenly, and the public sentiment and support often changes as we have different leadership come into our offices, or you have folks change that are in charge of a particular grant or service. Then a lot of times those things kind of can break down. And so from the prevention perspective, we talked a moment ago about prevention being connectors and your community health workers being sort of connectors. Those folks can help bridge some of those gaps and help fortify those connections so that fragmentation is less likely to be impactful overall, and we can pick up and move on much faster as things change and continue to be challenges for us. Another thing I want to mention, I mentioned this just a moment ago, but across all of those systems, everyone has different kinds of funding that is coming in, And some of that fragmentation sometimes is is really attributed to how the system is funded across the board. We have grants that are really useful and doing tremendous things. Then those end and something needs to change, and folks move over. We have a very layered system. We have structured grants that come into states that are part of the infrastructure, but then there's also kind of parachute grants that come in, or funds like opioid settlement dollars that kind of come in and overlay. And what it does is kind of creates a patchwork of reporting, priorities, ownership of various kinds of services that gets really incredibly complex at the community level. And so thinking about the system as a whole, but also sort of how the systems are financed in your community and in your states, and really taking an active role in making sure that you are advancing and strengthening those systems from the crisis care and overdose prevention perspective, because that is quite often top of mind, and we can get some leverage there if we are thinking about making sure that the systems are working together, both in the financing, reporting, and we're not doing double duty on collecting data and services and providing services that is unnecessary, and thinking creatively about how to meet the needs of the various financing mechanisms, grants, funding requirements together as a system. Okay, please advance. Mhm. You guys, I'm curious to hear more, hopefully later, about some of the things that you're doing in your communities, and within your sectors of the system. But I want to mention just some high impact opportunities that we are seeing. Hopefully, you guys are doing some of these. This is a quick list, not comprehensive at all. But some of the things that if you don't have these as a part of your system, things to consider prioritizing. Naloxone access and saturation. Of course, we've heard a ton about that and worked really hard on that in recent years. Expanding the use of non-clinical supports. Remember the rates that we gave you a moment ago about folks needing care of some sort and not getting it. What happens in those cases, whatever the reasons are that they are not seeking care or getting it, whether it's not available, or in many cases, they are not able to seek the level of care that potentially they need. So non-clinical supports that are able to help fortify them and then get them to that care in other ways, and meeting folks where they are. Expanding the behavioral health crisis continuum and overdose response network workforce. Workforce challenges continue to be pervasive everywhere. If any of you feel like you are 100% fully staffed in terms of your workforce, they have all the specialty training that they need, please let me know, because I would like to talk to you more and figure out how you did that. But it is something that is a perennial challenge for us in the field. Looking at the root causes, which we talked about ACEs some, we didn't spend a lot of time talking about risk and protective factors, but you can look in your community and you can look in your community and figure out what are the contributing factors and where are we seeing these more than others. And you can look at with your resources that you're going to have available to you, we're going to talk about today, really look at where to focus your service system, realizing that we certainly can't solve all the world's problems with the resources that we have. Sometimes we need to focus in on sort of high leverage points. Okay. So this is just a short list. You guys you'll have this available to you. We're gonna wrap up my section in just a moment so that we can hear a little bit more about the toolkit and how to put these tools into use. Go ahead and advance, please. But I do want to mention, just from the CSAP side of the house, we have at the community level something called Prevention Technology Transfer Centers. These folks are a hub for free and available training and technical assistance and support to communities. So this is not just prevention people. This is to communities who are working on systems level change. We have the link in there. If you aren't familiar with your PTTCs, there's an overarching one nationally, and then there's regional ones. And so it is their job specifically to know what is happening at the community level, some of the factors that we talked about how to anticipate, how to plan, how to drive and build those systems of care. These guys have this information. It is their job to help equip communities to do that. Again, I want to make it clear that this is not just prevention folks who can do this, who can use these resources. This is available to communities. So it's another resource for you to look at. If for no other reason, you can go on their websites. If you're not going to engage services or actually take trainings, there's so much information available there that will be helpful to you. So please do check out the PTTCs. Go ahead, please. And lastly, before I finish up, I want to mention a few of the things that SAMHSA, a few of our cornerstone events, campaigns, and observances that we consistently do in addition to our grants that I want you guys to be aware of. Please let us know if you want access to any of these services or you need more information about them. My contact information will be available. So Talk They Hear You is something to use in communities that really is focused on prevention of use, but also how to have those difficult conversations. It certainly is very a trauma-informed approach, much more of kind of a family-based approach, which for those of us who work in this field, it doesn't matter if you're an adult or a young person. Substance use does not happen in a vacuum, nor do crises. And quite often, figuring out how to have those conversations and talk about that at the family level is important. So there's tons of resources there for you if that is helpful to you. In addition to that, we have a Screen for Success screener. That is an initiative that is intended to provide quick and easy ways to look at areas of risk. It's an evidence-based tool that is available for you to use. We provide funding, and this is about to come out soon. We provide funding for Communities Talk. These are micro grants. It is specifically for you guys to all get your communities together and to talk about the issues that we are addressing today, which are how to work together, what's happening in the community, and how to proceed. And so like I said, they're micro grants. So it's not going to fund your service system. It is intended to bring everyone together and to be a catalyst for that. So be on the lookout for those. We also do this tagline is the 22nd. It's not the 22nd. But every year we have a National Prevention Day. For this year, it's at the top of February in National Harbor, where communities, coalitions, and folks, 5,000 people from all across the country come together. This is a free event that SAMHSA hosts. So if you would like to attend, all you have to do is register and show up. There's no cost there for that day. And then we also give tons of information out we have a prevention week in May, and then a prevention month. So these are kind of things that we put out there, again, to try to help be the glue that can bring these systems together. And this is just from CSAP. Across SAMHSA, there's also a ton of resources. And we're going to hear more about some of those specific resources from our friends speaking next. So I'm going to pass it off, but I will be here at the end of the conversation and look forward to hearing you guys' feedback in the chat and what questions you have at the end. So thank you.
Thank you so much, Sarah, for sharing your expertise and insights and the great work that's happening at CSAP. You've given us such a strong foundation today and what we're going to be talking about next. Next slide. So, as Sarah talked about, as many of you will know, and as you can see here, people with any mental illness, and particularly with a serious mental illness, are substantially more likely to report substance use and specifically opioid misuse. We just heard about some of these shared risk factors related to both mental health issues and substance use issues. In the context of crisis settings, this is so critical to consider and understand in order for us to effectively address risk and prevention. Next slide. So overdose risk is important for crisis response services for the crisis services response workforce to be aware of. And it might show up in two key ways in the field, right? So first, very critically, in many cases, the overdose itself is the crisis. These circumstances require urgent intervention and medical support for the individual. Understanding this risk can help crisis response workers be prepared and proactive in saving a life. The other way it might show up is if substance use is co-occurring with another mental health related crisis. So, for example, an individual called 988 in deep grief, unable to cope, and also was using a substance. This circumstance could further complicate the individual's experience. So, awareness of that among the crisis response teams can help workers engage with the individual in crisis, can help identify and plan follow-up care that best meets their specific needs. And incorporating resources into the crisis encounter can help lessen future overdose risk. So we're going to touch on some strategies that address both of these circumstances today. Next slide. So how do we address overdose risk in crisis settings? First, it's important to really lay the groundwork with a mindset and philosophy shift amongst staff. We're going to share some materials that will help you dig deeper into that topic. I'm also going to talk about a tangible tool, which Sarah already teased a bit, which is SAMHSA's Overdose Prevention and Response Toolkit. And you'll be able to use this, and I'll talk about how important these strategies are in crisis settings. And finally, but very importantly, we'll talk a bit about staff well-being and how organizations can support staff after they respond to an encounter with someone experiencing a crisis. Next slide. So the next few slides are going to look familiar to anyone who joined our July webinar on mindset and philosophy. To effectively integrate SUD services into the crisis continuum, we have to really make sure that the culture, the mindset, the philosophy of the staff, as well as the structures of the organization itself, makes it a welcoming, safe place, either virtual or a physical place for people with substance use issues. How we think influences how we behave. How we behave as individuals and organizations shapes our relationships with clients, and as a result, directly impacts integration efforts. One barrier to integrating substance use services into broader crisis care is that individuals, organizations, and sometimes even systems look at substance use disorders differently than mental health disorders. Sometimes we hear that clinicians and other helping professionals feel ill-equipped to screen, assess, treat, and respond to substance use and co-occurring disorders. Stigma and bias in our culture leads to individual value judgments. It can impact our ability to be empathetic and compassionate in the moment. So we covered this topic in detail in our previous webinar. I'm going to encourage you to watch that if you didn't have a chance, or revisit it if it's been a minute. And we're going to include a link. I see that Stephanie already dropped a link to the recording and the slides in the chat for your reference. Next slide. So here you can visually see this interconnectedness. An organization's culture directly impacts crisis staff well-being, and in turn impacts the client-staff relationship. Organizations that are trauma-informed and mindful of developing staff well-being and professional skills lead crisis staff to being self-aware, having their own crisis plans and self-care plans, and mindfully developing competencies as they go. When organizations are healthy and staff are focused on their own growth and well-being, it leads to more empathetic, compassionate relationships and shared decision-making, which is so critical in any crisis response. Next slide, please. So now we understand the context that we're in. We understand how to address these mindset shifts. How do we make the next step into action? So there are well-established evidence-based practices to respond to someone experiencing an overdose or who may be at imminent risk of experiencing one. SAMHSA's Toolkit provides a really important framework for how we adapt and implement these strategies specifically in crisis settings. Next slide, please. So many of you have probably seen the toolkit. This is a great resource from SAMHSA. My colleague is going to drop a link to it in the chat so that everyone has quick access to it. The toolkit lays out key strategies for responding to an overdose and preventing the next one. It can serve as both an educational tool and an implementation guide for these strategies. One critical thing that is needed in these contexts is how do you respond to the overdose? But again, it doesn't stop there. Next slide, please. So the toolkit provides steps to take before, during, and after an overdose. I'm going to cover them here at a really high level, but I encourage you to take a look at the toolkit itself. So first of all, any non-overdose crisis is an opportunity to assess someone's substance use and overdose risk, educate and provide access to opioid overdose reversal medications like naloxone or Narcan or nalmefene, or offer connections to SUD treatment in line with the person's recovery goals. So really hearkening back to that shared decision making. And then during an overdose event, and I want to be clear, this doesn't constitute a training on opioid overdose reversal, but we have a link here to how you can get more information for yourself or your team members on how to get that kind of training. But you can respond by checking for a response from the individual, giving Narcan, naloxone, nalmefene, supporting breathing. Sometimes it's called the rescue position or rescue breathing, and then calling 911 and connecting them to clinical services if EMS is not already present. The most important part about responding to an overdose event is to sustain or bring back breathing. It's not always the most critical to get someone alert and awake in that moment as long as breathing is maintained. The clinical steps can happen next. And then after, if someone regains consciousness after an overdose, provide them with opioid overdose reversal medications and test strips, which I will touch on a little bit more, for fentanyl or xylazine. In that moment, provide it to everyone who's there, be it their friends, family members, acquaintances. Discuss future risk reduction strategies and provide connections to treatment or other ongoing care as applicable. Next slide, please. So after an overdose is reversed, ongoing care is essential. Individuals may experience withdrawal symptoms, body aches, nausea. While uncomfortable, they're generally not life-threatening. However, that's an important moment to offer treatment options, peer support, behavioral health resources. If an individual ever declines further medical care in that moment, it's important to ensure that they do understand the risks and know that someone should be there to monitor them for at least the next few hours. The toolkit also goes a little bit into the importance of Good Samaritan laws, which provide legal protections for those assisting in overdose situations. These laws encourage people to seek emergency help without fear of legal repercussions. And providing support, understanding, and empathy to individuals who have experienced an overdose or who are with a friend who is experiencing an overdose is crucial for everyone's recovery and well-being. Next slide. Okay, so that step back, this other situation. What if you're not actively responding to an overdose? Well, then it's never been more critical to inform individuals about the risks associated with their substance use, even if they're not reporting active opioid use. And this really goes back to what Sarah brought up before and what so many of you are aware of already. The drug supply has never been more potent. This is largely due to fentanyl and various aspects of the drug supply, including in non-opioids. I'm also going to talk a little bit about this concept of the chocolate chip cookie effect. This is really important when you're talking to folks about drug checking services like fentanyl test strips in particular. Someone may test a small amount of their drugs, but it might not be the bit that has the fentanyl in it. And that means that they could have a kind of false sense of security that there's no fentanyl in whatever it is that they're using. So we have consistent data showing that fentanyl and its analogs are in both the opioid and non-opioid drug supply. This is an important piece of education for both crisis response systems and the people who are experiencing crises. That means that all potential interactions should come with some kind of overdose prevention and risk reduction, education, and the tools that go along with them. Be that dispensing opioid reversal medications like naloxone, providing these drug checking strips, and then providing the education that supports an individual and their community in taking care of themselves and others. And it's always critical in this work to get a wider community involved. The more that people are educated about these risks, the more people walking down the street know how to respond to an overdose, whether or not they have ever used drugs themselves. The more we engage community members broadly, the more we also combat stigma and negative misinformation, which again is going to support how people in crisis with any substance use issues are engaging with us in the crisis system. Next slide, please. So you may have also heard the phrase treatment as prevention. The toolkit will go into this a little bit as well. There are many evidence-based strategies we have, particularly for supporting people in recovery from opioid use disorder. Medications for opioid use disorder are very effective, and they can reduce both cravings and stabilize body functions, and overall reduce the risk of overdose death. The toolkit also discusses contingency management, which is really critical as we deal with polysubstance use, and specifically when folks are using non-opioids. So contingency management is a behavioral intervention that supports SUD recovery by intervening for folks towards, for supporting folks with behavioral interventions to address use of stimulants or other non-opioid substances, because these substances do lack current FDA medications. So medications for OUD as well as contingency management are both useful as we think about the spectrum of treatment opportunities offered to people before, during, or after a crisis, and as you work to prevent future ones. It's important to understand both the options available for individuals, be able to educate people on that, and provide or have direct connections to clinicians in the community who can provide all treatment options available. And as Sarah talked about, of course, the more integrated, easily accessible these opportunities are, the better. The lower the barrier to entry for treatment options, the more individuals can engage with this part of their recovery. The toolkit emphasizes that access to treatment should not be contingent upon participation in specific services. So again, that's important to consider when you're thinking about who's in your coalition for crisis services and who are you connecting individuals to. Next slide, please. So as I mentioned earlier, it's also critical to take care of staff who are responding to crisis events, particularly an overdose event. Those of us who have worked in this field know how difficult it can be to witness and respond to someone experiencing an overdose. It can also be very difficult to witness someone experiencing withdrawal. Ensuring these are both formal and informal mechanisms to support staff in all parts of the crisis continuum is so important in this work. Relying on staff to be able to share and advocate for their own well-being won't be enough and puts burden on folks who may be experiencing vicarious trauma. My colleagues put on a wonderful webinar on this topic earlier in the year on post-crisis debriefing and processing. Stephanie's dropped a link in the chat to this resource as well for anyone interested. I encourage you to take a look. Next slide, please. So in wrapping up, I want to really reiterate how common substance use is in crisis settings, particularly given the overlapping risk factors for mental health and substance use issues. I don't need to say this to many of you. You will completely understand and already have encountered this in your crisis services settings. But we also have effective tools and solutions that can be implemented, to address these issues. And they can be implemented across all three pillars of the crisis continuum to address overdose risk before, during, and after an overdose. Again, it starts with laying the foundation within our organizations, and it ends with taking care of individuals both experiencing the crisis and those who are responding to the crisis. So with that, I want to thank you all so much for joining us today. That was a lot of content, a lot of heavy content. So we want to give you a chance to engage as well. We've so appreciated that you've been dropping comments in the chat, engaging with us. I've seen a couple questions come through in the Q&A. I'm going to pass this now over to my colleague Megan to facilitate the next portion of the Q&A.
Thanks, Jennifer, and thank you, Sarah, so much for sharing with us. So yeah, we'd like to open it up to you all now for questions. Feel free to raise your hand and we can get you off mute if you'd like to ask aloud. We can answer questions from the chat, like Jennifer said earlier. We have some questions in the Q&A, but I do want to give any of those in the audience a chance to ask a question aloud if they would like to. I'll pause for just a second and let everyone find that courage to come off mute. All right. There, we do have one question in the chat that I'll pose to you if this is within your wheelhouse to answer. What suggestions are there when the communities that care student surveys aren't supported by legislation and in turn are not being conducted in schools, or if they are, there's an opt-out and opt-in approach? These surveys help pinpoint what focus areas are needed. Any thoughts on that?
Yeah, I might need to hear just a little bit more context. So can you repeat it one more time?
Yeah, and this question was from Sarah Drake. Sarah, if you would like to add any more context, please feel free. It says, what suggestions are there when the communities that care student surveys aren't supported by legislation and then aren't being conducted in schools, or if they are, there is an opt-in, opt-out process that's happening?
I'm a little, so not supported by legislation. I'm not entirely sure what that portion means. I'm also happy to, if you want to follow up and have a more kind of one-on-one conversation, I'm happy to do that post. But I will say that when you are implementing those programs in schools, it should be a part of the agreements that you set up with the schools when you're doing those models, that in order for them to anticipate the impact that they want, it has to be delivered with fidelity, meaning in the ways that the program is designed, and not necessarily 100%. There are, adaptations that can be made for the setting that you're in. But the point is that they cannot expect the outcomes that they want if you are not building into the MOU the times for doing those surveys in those community settings. And so my advice, I think, would be, again, without the legislation component, I don't have context for, but when you are setting up those services, build in those times for pre and post tests within the scope of the delivery of the programs and the MOUs, and then offer, when you're setting up those MOUs, ask for ways that they would like to make that data useful to them. A lot of times, particularly in a school setting or sometimes a community setting, there's a huge concern about what the results are going to look like, and kind of a fear of those not showing in a favorable light. And so having those conversations up front might ease some of the hesitation to allow for the surveys. The other thing that we do know is that, schools are surveyed, people are surveyed out and surveyed to death. And so I think figuring out if there are other surveys that they are doing, if there is a way to sort of dovetail those in some way so it doesn't feel like yet another tool, another survey that has to happen. And some of our, depending on what other survey instruments you're using in your state, some allow add-on questions. So that might be an option and an avenue too.
Yeah,
Hopefully.
so it sounds like increasing some of our partnerships in the school systems might be helpful. And like you said, leveraging other data sources that maybe already exist to see if that can get us some of the data pieces that we're hoping these surveys would provide for us.
Yeah.
All
Yeah.
right.
And sometimes it's asking the question about, if there's hesitation, what those things are, and then how you can help overcome that, and how you might be able to make that data useful to them. You might offer to do a community event, or to speak at if they have a venue that they bring families in, or bring people in, or any kind of to talk about the positive things, and to put that in a positive light. That might help ease some of that, but it kind of depends on what the root cause is for them.
Thank you, Sarah.
Mhm.
All right, let's see. Jonathan Bowen Leopold, I see your hand up if you'd like to come off mute and ask your question.
Yeah, hi, thank you. Yes. Don't throw away like older, sort of proven methods of helping people with substance use. I mean, when I started going to AA in the late 90s, they had a vat of coffee and like donuts and pastries, and you could smoke right outside the door. And that drew in a lot of people. Like there are a lot of people who will show up for free coffee, donuts, and pastries and be able to smoke outdoors near the door. So I mean, I just, don't throw away that, what used to help might still be,
Yeah, thank you, Jonathan, for contributing that. I think it's really important that we understand what creates those safe environments, those comfortable environments for people to be able to share and to get the support that they do need in a way that's meaningful for them. So I really appreciate you sharing that with us today. Let's see. Jennifer Sabin, I hope I pronounced that right. I see your hand up as
Yeah,
well.
you did.
Wonderful.
Yeah, so I'll circle back first to the first question and then ask my own, because we're experiencing that in New Hampshire as well. And so it's a little bit bigger. It's that statutorily, our lawmakers are not allowing non-academic surveys in schools. So it's not the schools, it's not the parents, it's our lawmakers saying, don't you dare ask our kids about drugs, because it gives them the idea to go do drugs. So we are fundamentally opposing that at the State House, and we're really worried about losing the data. And so I think this idea that there might be other places that the data exists that we could get it. New Hampshire right now has the YRBS is the only non-academic survey. And so people have been going after it because it's a carve out. And the attempt to make the data basically unusable is to make it opt in. Right. So they're saying, like, we don't even want to get rid of the YRBS. We just want people to have to opt in, but we know it's so that it goes away and becomes basically unusable. So I think that's happening in other places as well. So maybe that's another sort of conversation for later, but that's what came up for me in New Hampshire. Also in New Hampshire, as we continue to integrate our system and not just focus on substances separately from crisis, a lot of our more sort of bread and butter mental health partners really see the use of medication for substance use disorder as a short-term method to manage withdrawal symptoms and not a long-term treatment plan. And so outside of the things you already sent, really around the mind shift and philosophy sort of shift, are there recommendations when you're sort of bringing folks along who arguably are your people. There are people, but they sort of have this different theory about substance use disorder treatment and how it works and what it should look like, and that it probably should be only to manage symptoms, and then you should be smoking cigarettes and eating donuts and doing abstinence, right? And I think for some people that works, and there's a lot of people in crisis who will benefit from long-term medications for their substance use disorder, and how to sort of bring that along. Any insight you have would be great. Thanks so much.
So bringing folks along that might sort of have reservations or challenges with participating for one reason or another. That's what I'm hearing.
Yeah, or when we say like, hey, when folks with OUD and co-occurring schizoaffective present, they might need long-term medications for OUD, not just to get them off opioids and manage their withdrawal symptoms in the short term.
Yeah.
That we could use this the same way we would use an antipsychotic medication or an SSRI. This is like for long-term treatment of a chronic health condition.
Yeah. That's really that's essentially a culture shift in a lot of ways, and those take a long time to shift. So I'm going to make a comparison that hopefully will resonate. It's just what's coming to mind right now for me. So when you're working at the community level, you always have folks that are not on board or think about things differently. I'm going to talk about sort of school systems because this is what's coming to mind. We have had those challenges with school systems before who had a difficult time for a very long time shifting from, this is going back probably many years, but shifting their mindset from we just need an appropriate sort of stick. We need to find the silver bullet so that we change this particular thing that we are having a problem with right now. And we're really bought into how that's going to happen and really invested in this is the approach. Changing that mindset is always really, really difficult. Some of the ways that I try to come at that are to do some of that system work. And hopefully this is helpful, but to do some of that systems work and some of the ways that you change sort of culture is by looking at what's happening, having conversations about that. And so quite often in rooms of folks who have very different circumstances, you can't just say, this is not the right way. I don't agree, this is not the right way. What you can say is, okay, tell me more about what you're seeing. Okay, let's gather some facts about that. Let's look at what that looks like in our community, and then let's talk about that together. And that starts to give them kind of a safe place to examine what they're doing, and gives you also kind of a way to learn where they're at, so that you might not ever, especially if it's a value and resource-based sort of gap, you might not ever fully get there, but what you're hoping for is to get some movement and understanding in the right direction so that you can work together and as you're going forward. And to do that, honestly, I mean, those are hard conversations to have, but I think showing up and being genuine about why you're there and what you think is incredibly important, sort of having that dialogue and then giving folks an opportunity to explore that and have them be a part of that system. With regards to the statutes and the challenges there, what I'd like to do is if you want to follow up with me on email, I can connect you with some of your state kind of system providers and folks, particularly in your state that if you're not working with them would be good to work with. So some of your associations and your state system folks that can probably do some help advance some of those challenges. Legislative issues are their own beast. But I can connect you if you want to email me. And hopefully, Megan, we will throw my email on here.
Stephanie Lou's going to do that for me in just a minute. I did want to pause for a moment and see if Stephanie Legallo from the workstream wanted to chime in at all, because we do have another question that kind of piggybacks off this about how to jumpstart this culture shift. And I know that is her area of expertise. So Stephanie, if you'd like to add anything.
Sure. Yeah. Thanks for letting me talk for a second. So I've been thinking about this as Sarah was responding, and I agree. Having these difficult conversations, letting people express themselves. And I think sometimes the way to jumpstart that is through some sort of anti-stigma training. We've seen that be pretty effective in some states. And to ensure we're including peers in that type of training. So that would be my 2 cents to add in.
Thanks, Stephanie. And the other part to that question, Sarah or Stephanie might be able to answer this. Interested in formalizing substance use supports in the crisis system, because that might be new to some people in our audience. But any suggestions on where to start for crisis providers? So like our mobile crisis response, our 988 call center. Any ideas on where they might be able to get started in formalizing this SUD integration?
Mhm. Yeah, so every state has a point person that is the lead. So federal funders often require that there is a spokesperson in each state who is overseeing substance use systems. And so every state has an administrator that is officially in charge of doing that. So when SAMHSA puts out, all of the funding that comes from us into states, that's infrastructure funding for prevention, treatment, recovery services, there is someone in charge of that. And then that gets filtered out to your community-based service providers. And so that would be the place that I would suggest for you to go to for that. Um, sorry. NASDAQ is the association that is probably the fastest way for you to find your state person. However, if you need a connection, I can certainly help facilitate getting that for you and doing that introduction to your state designee who oversees and plans and directs the system that is quite often funded by various federal sources and state dollars.
Thank you.
Mhm.
Another question we have, talking more about post-crisis support and debriefing for staff and how beneficial that can be. Sarah, did you want to contribute any thoughts around that process, how we can be supportive of that?
This is usually
I'm happy to chime in if you'd like.
Yeah,
I just, of
please,
course,
yeah,
want to
chime in.
give you the opportunity.
Chime in
So,
with me, yes, please.
I know we had put in the chat a while back a link to a recording. We did a webinar around this post-crisis support and debriefing. So I'll just share a few brief thoughts from that webinar to try to answer this question. We know how important debriefing is. I think it's important that we also frame it in the correct definition of debriefing. A lot of times we see debriefing as just that time after the crisis or the trauma to talk about what happened. And what we're seeing is that it's really important for us to kind of shift our perspective on how a debriefing looks and how we run it. I say this to say the people involved in the crisis or the trauma shouldn't be the ones facilitating debriefing. So sometimes it's very important to have somebody from the outside, whether that's internal to your agency or external, someone else who can come in, hear the information that's being shared, help the individuals involved process their feelings about it, and giving that space to do some like systemic review. What happened? How can we improve upon this? What resources are in place for staff to get supports afterwards, even after debriefing, whether that's EAP, employer support groups, things like that. But making sure that this idea of a debriefing process is built into our procedures so that it's not just an ad hoc process that's happening when things get to be too much, when we see those signs of vicarious trauma or burnout. So really being intentional about setting the tone for your staff and advocating for this moving up correctly too, to those above you, that this become a process that is intentional and is continuously done so that we can provide some emotional support and security for our crisis workforce. But I love that we're paying attention to that more and interested in bringing that into our organizations more. Let's see what else. Some communities are seeing an increase in open drug use, and with new direction from the current administration and potential criminalization of substance users, what are some suggestions around community or client education to help mitigate the potential harms? That was a little loaded. I'll give you a second.
Yeah. Um, so I hear what you're saying. We, let's see, so I think we know what works already in our communities. I think we, I think it remains to be seen, what might happen in the future. And so I think it's important for us to stay anchored in the present and on what we know works, because quite honestly, we have faced all kinds of challenges over the years in this field. And so the challenge that you're presenting, we are working on kind of figuring out what are the best ways to operationalize that. SAMHSA certainly cares about making sure that we are following the administrative orders, but also that we are still relying on what we know works in this field. And so I want to remind us that even though there are these sort of anticipated changes in your community, to still continue to focus on what resources you have available and know that we've faced challenges and disruptions and shifts in priorities before, and to sort of go back to the systems that we work in together, because those are the things that are going to keep our communities safe and fortified. And so that was probably the closest answer I can give you on that. I mean, we are working on making sure that we are providing services in line with the executive orders, and like I said, making sure that we are staying true to what we know is effective in our communities and for the people who need our services, or your services. Is that your services? Yeah.
Thank you, Sarah. I think it's really important for us to take that perspective and remember what's happening in the here and now, the things that we can control, the things we can't control. I think anyone working in this field always has concerns and worries about what the days ahead of us could bring for a multitude of reasons. So keeping that perspective and that grounding, I think, is really helpful for us as we do this important work.
I mean, a lot of the shifts that were made during the pandemic. I mean, remember all of the changes that we had? That was unanticipated, unplanned. It was a sort of bombshell dropped into our service systems, and we were able to pivot and figure out how to do that work, and how to respond. And so sometimes in challenges, I mean, I guess this probably sounds overly optimistic, but really, don't forget that in those kinds of challenges are sometimes the things that drive us forward together stronger, and generate solutions that we wouldn't have necessarily thought of, if that were not the case. So
Thank you. All right. Unfortunately, folks, we're going to have to end this Q&A. We had so many questions. If your question wasn't able to be answered during this session, I want to remind you that Sarah graciously let us put her contact information in the chat, so you can pull that. And she's been lovely enough to offer that you can email her if you have any direct questions. We've also provided you earlier with the TTAC's email address, and we will show that to you at the end of this session. If you're looking for additional supports around SUD integration, specific to overdose risk reduction or just in general, please feel free to email us at the TTAC. We'd love to connect more, see what your individual needs are, and if we can provide you support. And if not, we'll connect you to somebody who can. So let's move back to our slides, please, Erica. All right, so we intended on doing a mindfulness minute right now. I'm going to kind of truncate that because I wanted to leave some time for questions. But I would like to invite you all to take a moment so that we can recenter ourselves, ground ourselves. Talking about overdose risk reduction can be a heavy and sometimes traumatic subject for us. As we shared during this presentation, it's likely that this has touched your life in some way, whether it's personal or professional. So we do want to take just a moment and some space for us to all decompress from this session. So I'm going to invite you, if you feel comfortable, to close your eyes. We're already off camera, so I'm going to do the same briefly. And I'm just going to ask you for a moment to focus on your breath. Just notice that physical sensation of the air coming in and out of your body. Paying attention to those spaces between your breath. Moving towards thinking about your body. We'll start with our toes, scrunching them, releasing them, relaxing, and continuing that up our bodies into our calves, our knees, our thighs. Continuing to let that exhale release any tension that we feel. Coming up through our hips, our pelvis, into our back, where I know I find the most tension. Letting that just subside as we exhale deeply. Lifting our shoulders up to our ears and then releasing them down, dropping completely. Allowing yourself to notice any areas of tightness. And exhaling again to try to release that tension from our bodies. Coming all the way up to our head. Feeling ourselves as we rest into our seat. Acknowledging maybe the feelings that have crossed our minds as we're taking deep breaths. Sensations that maybe have come. Letting ourselves breathe through them and simply be here where we are. And then taking a moment of gratitude for all of the individuals who have joined us this afternoon, contributed their ideas, their thoughts, and their presence to make this workshop meaningful. When you're ready, I'd invite you to open your eyes back up, gently shift in your seat, get accustomed to your surroundings again. We appreciate you participating in that. Hope it gave you a minute to kind of relax and remember the important work that you do and why we're all so needed in this space.